Going to present a trial looking at carboplatin plus various combinations of carboplatin and bevacizumab.
All right. Thank you very much, Dr. Ravdin. It's my pleasure to present these results on behalf of the CALGB and Alliance. Our funding sources for the study were the NCI CTEP, Genentech, the Breast Cancer Research Foundation, and we received additional funding from the American Recovery and Reinvestment Act of 2009. Triple-negative breast cancer accounts for about 20% of invasive breast cancers in the United States. We know that this is an aggressive type of cancer, that it is more common in blacks, Hispanics, younger women, and BRCA mutation carriers. And although there have been significant advances in the treatment of this disease over the last 20 years, we know that patients with early-stage triple-negative breast cancer remain at greater risk for early recurrence, and that the prognosis for patients with advanced-stage disease is very poor. In data presented at last year's San Antonio meeting, this meta-analysis confirmed what we already knew, that is that about a third of patients with stage 2 and 3 triple-negative breast cancer will achieve a pathologic complete response with standard neoadjuvant chemotherapy, and that these patients do significantly better than patients who have significant residual disease at surgery. One of the clinical goals of our study was to try to increase the percentage of patients who achieved a pathologic complete response. And the rationale for our study, we took our standard control regimen based on results from prior large adjuvant trials that had demonstrated benefits to this approach in patients with triple-negative disease. We decided to study the addition of carboplatin based on its activity in patients with BRCA mutation-related cancers, the similarities between these cancers and sporadic triple-negative cancers, and high pathologic complete response rates in pilot studies in which carboplatin was added to standard chemotherapy. We decided to study bevacizumab based on improvements in response rate and time to progression with the addition of this agent in patients with metastatic triple-negative breast cancer. This is the design of the study, and I know that it looks like a 4-arm randomized study, but it was a randomized phase 2 with a 2-by-2 randomization. What that means is the study was powered to compare the 2 arms of patients who received carboplatin with the 2 arms who did not, and the 2 arms who received bevacizumab with the 2 arms that did not. The study was not powered to compare the individual treatment arms. All patients received 12 weeks of weekly paclitaxel followed by 4 cycles of dose-dense AC. Half of the patients also received carboplatin at an AUC of 6 every 3 weeks for 4 cycles during the weekly paclitaxel, and half of the patients also received bevacizumab, 10 milligrams per kilogram every 2 weeks, for a total of 9 doses. We required research biopsies before the start of chemotherapy. I will not be presenting any data on the correlative studies at this point. And following completion of chemotherapy, all patients underwent surgery, but surgical decisions, radiation oncology decisions were made by the treating physicians. No postoperative chemotherapy or other systemic therapy was planned. Our primary endpoint was pathologic complete response in the breast. We also did look, though, at pathologic complete response in both the breast and the axillary lymph nodes. And we're also going to present today interaction between carboplatin and bevacizumab on the PCR endpoint, treatment delivery, toxicity, and serious adverse events. We will not at this point be talking about recurrence-free survival or overall survival or looking at response rates in specific patient subsets. Patients were eligible for the study if they had clinical stage 2 or 3 disease, no contraindication to treatment with bevacizumab, and standard baseline evaluation. In terms of the 443 patients that we enrolled on the study over 36 months, a majority were between the ages of 40 and 59. 72% were white, but we did have a good representation of blacks, having reached out to that community and to centers that serve that community. 2/3 of the patients had clinical stage 2 disease. 66% had tumors between 2 and 5 centimeters in size, and slightly over half were node positive, and the treatment arms were well balanced for these characteristics. If we turn first to toxicities of treatment, you can see that the addition of carboplatin in the 2 arms to the right did increase the percentage of patients who had grade 3 or worse neutropenia and thrombocytopenia, but only the group that got both carboplatin and bevacizumab had higher rates of febrile neutropenia. As we see in studies in which bevacizumab is tested, About 10% of the patients on the 2 arms that got bevacizumab had grade 3 hypertension, and there was a small but significant incidence of bleeding and thrombotic complications on the bevacizumab arms. And if we turn to serious adverse events, clearly this number was increased with the addition of either carboplatin or bevacizumab, but the more concerning side effects were seen in the bevacizumab arms. And there was a slightly higher rate of post-surgical complications in patients who had received bevacizumab, even though the drug had been stopped a minimum of 6 weeks before their surgery. These are our primary results. This is looking at pathologic complete response rates with the addition of carboplatin. So for our primary endpoint on the left, pathologic complete response rate in the breast only increased from 46% in patients who did not receive carboplatin to 60% in patients who did. The odds ratio on that is 1.76, and it was highly statistically significant with a p-value of 0.0018. If we look at the secondary endpoint of pathologic complete response in the breast and axilla, that also increased by 13% with an odds ratio of 1.71 and a p-value of 0.0029. If we turn to the results with bevacizumab, we also saw an increase in the pathologic complete response rate in the breast with bevacizumab from 48% to 59% and a p-value of 0.0089. Looking at complete responses in the breast and axilla, this number did increase, but this did not reach statistical significance. Here are the results actually for the individual arms. We looked to see, because the patients who had received both carboplatin and bevacizumab had the highest pathologic complete response rate in the breast, 67%. We looked to see whether there was a statistically significant interaction between the 2 drugs, that is, suggesting that there was a more than additive effect of adding the 2 drugs together, and we did not find evidence of such an interaction, either for the PCR in the breast or for the PCR in the breast and axilla. We now have 2 randomized studies demonstrating increases in the pathologic complete response rate with the addition of carboplatin to a chemotherapy regimen, neither powered for relapse-free survival or overall survival. What is the optimal carboplatin dose and schedule for efficacy and toxicity? We don't know that, whether it is the every 3-week at an AUC of 6 that we used or the AUC 2 used in the Gephardt-6 study. And what should be the baseline chemotherapy regimen? I would say that the chemotherapy regimen that we used was in general better tolerated than the one used in the Gephardt-6 with a much lower percentage of patients discontinuing treatment due to toxicity. What about the role of bevacizumab? Well, now there have been 3 randomized studies demonstrating increases in pathologic complete response rates, although the NSABP-B40 results were not statistically significant. Again, none were powered really to look at relapse-free or overall survival. And in all of these studies, there were increases in toxicities, including febrile neutropenia, hypertension, bleeding, clotting, and post-op complications. And we also have the results of a large adjuvant study that failed to show a benefit to the addition of bevacizumab to adjuvant chemotherapy in triple-negative disease. So in summary, in stage 2 to 3 triple-negative breast cancer, the addition of carboplatin to standard neoadjuvant chemotherapy significantly increased the path-CR rates. The addition of bevacizumab significantly increased the path-CR breast rate, but not the path-CR breast and axilla rate. Correlative studies are pending to see if we can identify markers of response or resistance to the standard and investigational regimens. So the first question is, should carboplatin be routinely added to neoadjuvant chemotherapy for stage 2 to 3 triple-negative breast cancer? With the caveat that we do not have long-term results. We don't know if increasing the pathologic complete response rate will result in significant improvements in recurrence-free or overall survival. But I think if you're looking in the neoadjuvant setting, my answer to that question would be yes. What about bevacizumab? It did increase the pathologic complete response rates, but at the cost of significant toxicities, and I don't think that that should be routinely added to neoadjuvant chemotherapy. Is a phase 3 randomized adjuvant or neoadjuvant trial powered to determine if the addition of carboplatin to standard chemotherapy improves relapse-free or overall survival in stage 1 to 3 triple-negative breast cancer? I think it would be very interesting. I'm not sure we can get such a study going. But at this point, what we have are the pre-op data, the pathologic complete response data, and for carboplatin, they're encouraging. I want to thank my colleagues, co-investigators, sponsors, and of course the patients who participated in the study. Thank you very much.
Thank you. Mike, first question.
Yeah, Michael Smith. Is this long? Yeah. Michael Smith, MedPage Today. A
I have a couple of questions, if you don't mind. The first one is, I'm not clear on the relationship of pathologic complete response to anything else. I'm sort of used to seeing trials that give us progression-free survival or overall survival or both. So can you maybe elucidate that a little bit? What does PCR mean in terms of clinical responses?
Okay. Well, I mean, a pathologic complete response means that when the patient is taken to surgery, there is no residual viable disease in either the breast or the breast and the lymph nodes. And this is, you could call it an intermediate endpoint. In other words, we know from individual studies, and we also know from the meta-analysis, that patients who achieve a pathologic complete response are much less likely to recur and die of their disease. And this is what led the FDA to issue the guidance within the past year that a significant increase in the pathologic complete response rate could lead to approval of a drug or expansion of a label while waiting for relapse-free survival and overall survival results. So in other words, you say to me, well, Dr. Sikov, are the patients who achieved a pathologic complete response with the addition of carboplatin, are they less likely to recur and more likely to survive? The answer is, our supposition is that they are, but we haven't proved that yet.
Okay, the second question then is, what can clinicians take from this? You've got now a study in which you argue that bevacizumab really doesn't add a whole lot and takes away some toxicities. But what should people be thinking about doing in these patients? Should they be adding carboplatin in the neoadjuvant setting?
You know, I think based on these results and those presented by Dr. von Minkwitz at ASCO just 6 months ago, I think if you have decided that a patient with triple-negative breast cancer, should receive neoadjuvant chemotherapy based on the size of the tumor, based on a desire to improve their chance for breast conservation, then I think it makes sense to add carboplatin to your neoadjuvant regimen, and that you can comfortably do so with acceptable additional toxicities.
I would interject one thing here, and that is that there are going to be the presentations by yourself and also by Dr. Rugo, both of which look at carboplatin-based regimens and an improvement on their basis are going to be discussed again at the meeting by a discussant immediately after those two presentations. Yes. So you'll have a chance to actually see a high-level discussion of the role of carboplatin in breast cancer.
Yeah. Dr. von Minkwitz, you're the PI of Gephardt-Sixto, right? I'm here. Okay. Can you comment on what Dr. Sikov said about the differences in your two regimens? Yours used a slightly different backbone, or?
Yeah, the regimen is completely different. We had a weekly regimen. We had a combination with an anthracycline. It was 18 weeks instead of 24 weeks. So there were various differences between the regimens. One thing that I can say is that we had to reduce the dose of carboplatin from AUC 2 to 1.5, but we have now done further safety analysis of the study, and we have seen that the 1.5 dose is much better tolerated, and the presented here, dose discontinuations were much less with this lower dose. So we have various options, but at the end, it's a more experimental treatment than the one that is used by Bill.
Okay, thank you.
All right, then, as we're getting ready to wrap up, just a reminder, there's been a lot of traffic and a lot of interest in the I-SPY 2 trial, and we do have 3 co-authors in the room, Laura Esserman, Don